Ladies and gentlemen, friends, presenting CME number 785 to you.
So thank you, Dr. Chauhan. Where the forum is concerned, I happen to be a student and let that be my only introduction, which is something that I am proud of. And to discuss today's evening topic in the CME, we have a very eminent speaker, Dr. Suman Bhandari, who has been introduced to you right now. We will be talking about the journey of interventional cardiology over the years. Long ago, when Grunzig and Amplas they started doing catheterizations, etc., initially with rigid catheters and then going over to flexible ones and then rushing on to the fluoroscopy rooms. Nobody could have imagined that what journey it would take. And afterwards, when Professor Brownwald, in his very famous speech at the ACC long ago, somewhere in the 70s, if I'm not wrong, when he mentioned that interventional cardiology would be one of the ways forward, people looked at it very, very incredulously. That what is he saying? I mean, to do away with coronary artery disease and other things by putting in a catheter, opening up the channel, it was like akin to opening up a drain to remove the clogs. But then, be that as it may, it has travelled a huge journey to the present circumstances and the situation that we see. And what we see now that we have marvelous tools of technology which has come to the aid of the interventional cardiologist, which is, has redefined lives for very many people, not only in terms of coronary artery disease, but also in electrophysiology. We know about pacemakers, state-of-the-art things, which have actually revolutionized life and prolonged the longevity. Also, not to miss the quality of life. So, to put it all in a nutshell and to take the meeting forward, let me invite Dr. Suman Bhandari sir. He is a very prolific speaker, very senior cardiologist with extremely proficient hands. My pleasure to invite him to deliver his talk.
Thank you, Dr. SenGupta and Dr. Chauhan for the kind introduction. In fact, when I came into the Panchil rendezvous, so I asked them where the meeting was. So they said, oh, Dr. Chauhan ki meeting. So that's how I came in. So, in fact, this place is little, deja vu for me because when I started as Scots, this was the place where I did the first CME. And so, coming back to Scots again, it's probably going to be a good journey again. So, coming to the topic, I'm just going to, over the few 15-20 minutes, introduce you to what advances we have seen and what the future looks like, and for your patients, and how exciting this field has become. So, this is from a science fiction movie in which men are miniaturized and put into a spaceship which goes through the capillaries and is trying to find out the splinter in a very famous or a very VIP person. So this is how the science fiction for angioplasty started. No one could believe that balloons would be used to dilate coronary arteries. The peripheral arteries were the beginning. And what we got was these cracks, and it's somehow a miracle that this did do well. This is Andrews Grunzig. These are the catheters which he made in his kitchen with his wife and the chief lady technician. This is the first patient in 1977 who was, as we were told, sharing a room with a person who just had a bypass surgery in Zurich. And he was a young man, 45 years, and saw the big scar and what problem this gentleman had. And when Andrews Grunzig offered him this first therapy world, this is what he agreed to have. And this was the. Can we please keep quiet in that corner? If you don't mind, you get disturbed. So this is in 2000 follow-up showing that pristine LED result with a balloon, and in fact 37 years later also this gentleman never had bypass surgery, had multiple stents in the right and the LED, but that was Grunzig's belief that if you intervened early on, you would convert people who had three-vessel disease or left main into frequent angioplasties, but you could avoid bypass surgery. So this is the first patient who did well and who then paved the way for this new therapy to be sown, the seeds to be sown for this new therapy. In fact, in ACC, this gentleman was presented by Bernie Meyer, who was the resident for Grunzig and was then the chief of Zurich. And then we started to have the metal stents, which are very easy. You go percutaneous through the femoral or radial route. You blow up the stent, which is a laser cut stainless steel tube. Now, of course, you have newer versions, which we will show you. And it's very easy. Just you inflate the balloon, you deflate. It's a 15-20 minute procedure for a single vessel, and the patient can easily go home in a day or two. If you see the results with bare metal, then you see that as compared to surgery at that time, the mortality was no different, and only thing which was, this is the 1 year mortality, only thing which was obvious was a recurrence of 12 to 13% more than angioplasty, than surgery. So, and if you looked at vessel which was 3.5 or 4 millimeter, and even a long lesion 35 millimeter or so, you had a very less recurrence in single digits, 13% or 11% or 9% if you had even had a 30 millimeter long stent. But if you had a thin vessel, even a small lesion of 10 to 14 produced a doubling of restenosis. So it didn't work so well in the small vessels, which was the real need of the hour. And so then we started to have the new drug-eluting balloons, which were anti-cancer drugs mounted on the stent, sirolimus, and then you didn't have, this was the first cipher stent, no exuberant new intima formation if you had them coated with rapamycin. And that's what the first stent was called cipher for zero, because 15-20 patients which were first in man had a 0% restenosis. But that's not true, because we did find restenosis and it was as much as 9.2% versus 20% with the bare metal. This is a very old slide from the Texas stent, which is first generation, no more available. And what it showed is that if you have a bare metal in the red and you have a long lesion more than 15, and if you have less than 2.5 vessel, then your restenosis in the bare metal is 30% or so. But in the green, whatever be the length, whatever be the diameter, your recurrence is decapitated to less than 10%. So that's the reason that drug-eluting stents became so favorable, because whatever be the length, whatever be the diameter, we could decapitate the recurrence to a very predictable level. And a lot of trials came in, not only from Cipher but from many other companies, Medtronic, Boston, and this is, of course, Cipher was the first, so many of the prophecies. Can you just take my phone? Someone is calling you. You can just tell them that I'm in a meeting. And the Cipher is supposed to have done as well if you had bypass surgery. And when you look at the angioplasties or the surgeries which have happened in that era, if you could then think about 50% could actually go to angioplasty. So as stents evolved, as drug-eluting stents evolved, even initially in the early era of their development, it was found retrospectively that close to 50% could go for surgery, could go for angioplasty, those who were selected for surgery. And left main was considered a surgeon's domain, but if you look at the ostium and body, the recurrence, because it's a very large vessel, 4.5, 5 millimeter, the ostium body recurrence with a drug-eluting stent was close to 0% and better than surgery. It's only where the distal vessel is there, left main, that recurrence is more. But there are ways we can predict scoring, use the syntax score, and of course many new stents came in, even diabetes, the resolute data showed it could be very less of recurrence or STMI. And then we had an era of the bioabsorbable stent, where we felt that stent, if they get reabsorbed and you are left with nothing in 2-3 years, then probably that would be a great thing. You would have no caging and you would have good late lumen enlargement. And these are all the theoretical things, and of course a lot of hype happened. This is just a small video for those who may have not seen angiogram or PCI in the lab. So this is what we do. This is the wire which is shaped depending on where the vessel is, the stenosis in the vessel is, and so we then introduce this wire through the already guide catheter, which is through the tube hole, and thus the wire being negotiated in the blockage, and you'll see that gradually it moves, and then you can follow it up with a balloon end which is being introduced, and once you have made a passage with the balloon, then you can put the required length of the stent and the diameter based on your assessment of the vessel size. So that's the balloon opening up the artery, the stent being placed, and then you can see as it inflates, and of course there's some narrowing happening, but which is open. And so it's a longer video, but I'll just end it up here. There are ways to also see where the blockage is more than 80% by doing FFR. But bypass surgery is you're bypassing the blockage through an internal memory artery to the LAD, or putting a vein from the aorta to beyond the RCA or SERV. And what happens is that you need to open up the chest, you need to put them occasionally on bypass, but now most often you do them beating heart. But there is some time of recovery, and there is some reason that angioplasty now can go through many indications where medicine alone or surgery alone would be effective. It can go through a longer area of severity. we started with a small bleb, and now it's, of course, this is way back in 80s or 90s. Can we not make that noise, please? And gradually it has eaten up into surgery and medical therapy. And as we have better stents, with balloon we could only do a little bit of angioplasty, with stents, bare metal, drug-eluting, and gradually from 2006 onwards, 2003 was when the cipher was introduced. We also have a concept of putting Lima into the LED and following it up with stents in Circ and RCA, which is called hybrid. Hasn't taken up much. It's a beautiful concept, but hasn't taken up much. And we do need a team support for all our interventions, which is a clinical cardiologist, a referring cardiologist like you all, cardiac surgeon, an interventionalist, and the center, of course, is the patient. And the future is recurrence of dissolving stents. We probably will have some of these come back, shorter dual antiplatelet. We have better antithrombotics and better antiplatelets, and probably we could have simulators like you have the Boeing people teach pilots, and this skill can then be transferred much quicker. These are some of the areas where we still need to work, and this is some of the illustrations from calcified lesions. You can see the rotablator being used. This is the blackish area you'll see as calcification into LED diagonal, and then you do a imaging and you can assess there's a lot of calcium around. This is the calcium, nearly 360 degrees, and then you use a cutting balloon to open up the vessel and then stent it, and still we could not, this is the cutting balloon, then the stent still was not opened, and then you used a double layer balloon, which is the OPN balloon, which can go up to 40 atmospheres or more, and without enlarging, it remains the same size, and you can make 1:1 ratio and then open it up. So that's what we called a combo therapy, and was published with Gary Mills, who's the father of imaging, and he co-authored with me on this paper, and this was published recently. Another way to open up the calcium is by doing lithotripsy. We are familiar with lithotripsy being done for calcium in the renal stones, and that's right. It came with inferior MI. The right was opened at one sitting, and then we addressed the LED, again did imaging, and we could then know the diameter of the vessel, how much is the calcium. This is an IVL balloon. It looks like the similar balloon, but has two emitters on it, like one emitter here and here. And this, with the dye-filled emitters, produces a high wave ultrasonic waves which go up to the calcium in the side, and the energy level is up to 50 atmospheres. So this is very user-friendly against a rotablator, which needs a sort of a learning curve. And in fact, we're doing a workshop this Sunday on behalf of CSI Delhi branch, of which I am currently the president. And we'll go and discuss about rotablator and other ways of looking at calcium, and also intravascular ultrasound. So you can see the stent so well, and you can see how well it is opposed. All these images are very easily obtainable. And this is another lady who came with gross failure, had bad calcified right, requiring an LED, requiring, this is very acute bend, and when you do a rota, you can actually dissect and produce bad perforation or dissection. And here IVL, which is just a balloon, comes handy, and we could open up this highly calcified vessel and use the onyx, which is from Medtronic, will share its characteristics, but I think that's the best deliverable stent, and for calcium, onyx does wonders. Similarly, the right required a balloon, IVL balloon, to open up, and then we again used onyx with good result. These are some of the studies which show that this works very well, and this is the left main calcified left main, an LED which is stent already there, and using imaging we could understand that this is a 360-degree calcium which was opened with a cutting balloon, and what is called a Wolverine, 3/6 at 14 atmosphere, and we could then finish off the procedure. So when you control a calcium with an intravascular imaging, either OCT or intravascular ultrasound, you get better knowledge of the calcium and better ways of understanding where and what to do. I think this is a very apt quote from Disney. One of the reporters asked him, "Sir, when will the project, the Disney World, be finished?" Because every time he came, there was always a new game park come up, and so Disney told him, never, not as long as there is imagination left in the world. So that's true for any evolving field. As long as the field evolves, you'll continue to have a project which is incomplete. We now also have some better antiplatelets. We have newer generation drug-eluting stents, which I will just give a clip at the end from Medtronic, who are the sponsors for today evening. The benefit of the onyx, and also their blood pressure control. Also, just to introduce you about tower, it has become a fashion to not have aortic valve surgery after especially 65. The etiology is very similar to coronary artery disease, and the same risk factors, and we have a lot of bicuspid, 30-40% in India, and it's about 4% over 85 years, and 2% people over 65. It's like a left main, because once severe aortic stenosis gets symptomatic with angina, syncope or failure, their survival is in years. If they are in failure, and 2.5 years with syncope and angina, maybe 4 years. So unless we intervene in aortic stenosis which is symptomatic, they'll have a quick downward curve, and the more severe the aortic stenosis in terms of gradient, the more the mortality. So survival is just 20% if they are 4 to 5 millimeter per second, and you can divide them into various categories. Timing of aortic valve replacement is symptomatic and more than 65 years, and it's becoming now more and more driven towards tower, and it's probably be another 5-10 years like angioplasty has beaten surgery. I think percutaneous technique will beat aortic valve surgery. The only downside is the enormous cost. For angioplasty, surgery was always higher than angioplasty, even in the US. But here it was equivalent. So this is one area, various ways of doing it. This is a core valve from Medtronic, which is self-expanding. You have the Indian valve, my valve, you have Edward valve, which are balloon expandable, and many studies in the US have found that this is the way to go ahead, even in low-risk patients. And so if you don't operate, that's how the CBRT of, you just have 20% survival at 2 years for CBRS. So I would think it's just as good or bad as a left main. And the durability of the surgical valve is well known. Core valve also has been well studied, so also my valve, etc. And the current paradigm is that the patient should be at the center of the heart team. It's not just the performing interventionalist or the surgeon who decides, but patient preference should also be taken into consideration. And of course, we need many modalities like CT scan, etc. to be sure about what is the best way to go ahead. These are some of the criteria. So surgical valve, if life expectancy more than 20 years and more than 80 years is class 1 indication for doing a tower, and because the risk of surgery is high and survival is just 15 years or so. Many ways to know what is the best strategy, surgical or aortic, but it's mainly increasing incidence of percutaneous aortic valve surgery, which is happening and all over the world. And 2-year outcome versus surgical, even in low risk, has been studied and is found to be very comparable. So we're sure of one thing, and that is even if we were patients or a family becomes a patient, we know everyone wants a less invasive but a safe and durable procedure. So percutaneous therapies are here to stay and will continue to innovate and become better on. I'll just show you a few. Can you help me? Just 2-3 slides about. No. Just and then we can.
Thank you, Dr. Bhandari, sir, for taking us through a very fascinating journey about the development of interventional cardiology and looking at additional things like FFR, OCT and IVUS, which is used to guide your procedures, and also the development in terms of TAVR and other things that you showed at the end, which is really fascinating. Just a quick question before I leave it open for the forum for discussion. How do you think that the robotics in times to come would change the, the involvement of the interventional cardiologist?
So, a very good question. I think India has 3-4 centers where robotic angioplasty is being done. The advantage is that you can do it from a distance as well. So if you have a remote area, you can guide intervention from there, and if it's a complex case, you can help the local team there. But if you're doing it in a tertiary center yourself, the advantage is that you don't get radiation much because you are sitting behind the radiation in an office and an assistant, a nurse or your assistant is helping you a little bit only during that time. So orthopedic problems also which happen, CA, brain can happen. So all those operator problems will reduce. Some complex cases, the robotic navigation makes angioplasty wire crossing easier, even in CTO. So complex cases, may be handled much easier. Only thing is the cost and some expertise required to get this new technique.
So in the setup that you are working, which is one of the prime setups in the country, are you in the process of having a robotic setup, or is it going to be more individualized and personality based?
I don't think we are looking at robotic because of cost at this time.
Right, sir.
But if
Can I just, sorry sir, can I just the people to not to tinker with the plates and the glasses for the time being, because too much of disturbance. Sir is speaking, please. Please sir. Yes sir, the boss.
so, we don't have very good data to suggest that it is class 1 indication. Class 1 means it must be robotic. So it's still to be operated, so very as next 5 years or so,
Right, sir.
we realize that CTO crossing manually maybe 30%, with the robotic it becomes 80%. Then you will have a niche areas where robotic will be needed.
Right. Thank you so much. The forum is open for discussion. I would request the people to be crisp in their questioning, sir.
So, what a wonderful talk, Dr. Bhandari. Always pleasure to listen to you. So, how many angioplasties? 75,000?
Yeah.
What else? So, I was just listening to you and I noted down some questions. So, left main disease, the recommendations are to revascularize. PCI or cabbage? Sir.
So I showed you the score, the syntax score. For the ostium, for the body angioplasty, no question about surgery. But if it's extending to the circ and LAD, what we call distal left main, then you have to see whether it's calcified, how big the vessel is, whether 2-stent strategy or 1-stent strategy, and what is the score. So all those things,
Right.
but we are doing more and more left main with imaging and getting better results.
So, repeat revascularizations, probably more common in PCIs at 3 years and is often associated with increased mortality at 30 days. This is what the Lancet in November 2007 said.
So, angioplasty is always going to be well scrutinized. We don't know about surgery. There was very early on an article which I as a novice showed it to Dr. Trahan, and what it said is that when you do surgery, 30% require immediate angioplasty because the grafts fail, you don't, you do a too tight closure, and it used to happen. So, but it's kept under the curtain. So things happen with surgery. We have seen it even in the acute phase. But cardiologists, interventionists have been taught by Grunzig to bring it out in the open, and that's where you learn.
But Dr. Bhandari, I think the repeat revascularizations after PCI is more common as compared to the cabbage.
So that is true, but it's coming down with drug-eluting stents,
Right.
which are getting to 5-8% now.
Okay, now my next question would be, how often do you use IVS, especially in CTOs, left main, bifurcation, complex lesions? Improved outcomes were seen in the ultimate trial, and they said 50% risk reduction in mortality and target vessel failure, and can guide stent size, good estimation of calcium score as well. The IVS.
So I had a talk on Sunday.
Okay.
So
Just a short way.
you will find a less informed person than me, or a more informed,
sure.
because I've circulated. See, I don't know if you remember the early stenting days. We used to give Coumadin we used to give lot of heparin, lot of Coumadin and big hematomas. And so I went through the original Colombo paper, and what it showed is that when you do angiogram of patients who have had Palmer-Schatz in that era, Palmer-Schatz stent came with a sleeve, so you remove the sleeve and then you inflated the balloon. It looked like a very good lesion, which was angiographically fine. When you did IVUS, if it was less than 10-11 atmosphere opening up, it was dilated to just 4 millimeter square, which is very less. And when you used a 15 atmosphere, it became 10.5. So angiogram does not give us a good idea. Only thing we have known from IVUS that you want to go high pressure. So we have learned that any stent you do, go at 15, 18, 20, and then only you will expand. and we also now have the stent boost, which is something like a poor man's IVUS. So IVUS helps, but the penetration in US is less than 20%. In India is less than 2%. In UK, Europe is about 6 to 10%.
So why do we not use IVUS?
Because the cost, thinking of more time, you are doing a procedure, you have more list to do, so and you think that angiogram is giving you reasonable outcomes.
Okay. Bhandari, tell us a little about the CTOs. So, what about perforations in CTO? Why I said that was, recently an article was published in JAC and regarding a 62-year-old man who had a CTO in the LAD, and PCI was done, and he had a hemodynamic collapse with a blood pressure of 60/40, cardiac tamponade, malignant ventricular arrhythmias, and 5 coils had to be put to save the fissure in the perforated vessel. So how common? I think it's just about 5%. What do you say?
Yeah, it's there, but very less. And it will depend on how much risk you are taking. How blind you want to go. So, Indians, very few people do retrograde, going through the septals and going through the other west side. And you need a special training, I would say, to do CTO safely. It's not everyone's bread and butter. So we do integrate, we do some, but CTO procedures require 3-4 hours sometimes require them to come back the next day, and you should be able to put in coils, you should be an expert. If you go to Japan where they do CTOs, most labs will be doing just 2 procedures a day. So they have the whole day to do before lunch 1 procedure, after lunch another procedure.
Okay, so Dr. Bhandari, tell us, in your subset of patients, when you do coronary angiograms, how many percentage of the people would have CTO? Would you say about 30% or less?
No, CTO is about 10-15%.
10 to 15%. Okay. In the recently concluded Euro PCR, May 15th to 20th in Paris, they talked a little about the new QFR, that is the quantitative flow ratio, and the decision study said it compared with the invasive FFR and in multi-vessel disease, in which they said the risk of the vessel injury and access procedure time was more in the invasive FR as compared to the new QFR. So, what do you say about that? The new QFR?
See, it's an evolving field,
right?
But very interesting because when you do a CT, now you can sometimes not see through a calcified lesion, but you can get the flow. So if you get flows, you get the FFR, then it makes more sense to do a CT angio and get more information.
Right. So my last question on CT angio. So ultra high resolution has a class 1 recommendation for symptomatic CAD. But there are some concerns regarding overestimation and overdiagnosing of the stenosis, especially in calcified lesions. Sir.
No, so that is the drawback of CT angio, because you are superimposing 2-3 cycles on each other, and you can't see through the calcium. You're not seeing the lumen, you're seeing outside the vessel. So, but gradually it is gaining ground in chronic stable angina that people who are symptomatic, you do a CT angio, follow them up. If they become more symptomatic, then only do an angio.
Thank you, sir.
So just a quick question before, for the benefit of all, modern generation stents, how much of dual antiplatelet therapy do you recommend? Number one. Number two, if you have a multi-vessel complex angioplasty coming up, how exactly do you decide which is going to get a DES and which is can be a bare metal stent?
So taking your second question first, bare metal stent was considered useful if you were planning a non-cardiac surgery in say about 4 weeks, because then you felt the bare metal would get endothelialized and you could go for surgery with a single antiplatelet rather than dual antiplatelet. But now most studies have shown, and especially registry data of about more than 20,000 patients, that the drug-eluting stent even in that scenario does better. So bare metal is out.
So given the option, if there are 3 lesions in 3 different vessels, you'd go ahead and do all 3.
Even if it's 2 millimeter, even if it's 4 millimeter. Earlier, Renu Virmani was very much against putting a drug-eluting stent in acute MI in bigger vessels than 3.5. That's the pathologist's view.
He didn't want for herself also.
That's the pathologist's view, because she felt it was pro-inflammatory, but clinical grounds, drug-eluting stent, and only drug-eluting stent. And even for the balloon, drug-eluting balloon, for a thin vessel, first choice is a drug-eluting stent, and then a drug-eluting balloon.
How often do you feel the need to do an FFR surgery?
FFR, if your eyes are bad, then.
And the
Or
continuation of the DAPT, as I said.
DAPT, no, FFR, I'm just laughing it off, but there are labs which do a lot of FFR. And the reason is that sometimes the other vessels are borderline, but if the FFR is more than 0.8, then it means that that area is large and has a lot of vulnerable plaques in there. So it becomes a high risk even if it's 70%, and another vessel may be 90% largely infarcted and may have very less change in the FFR. So in fact, Grunzig was the first, when he had a lesion, he would measure the pressure gradient through the balloon. So the balloon lumen, and we did that initially at Escorts in some intermediate lesions. So if you have a gradient of more than 20, then only you went in and did a balloon, because at that time balloon was unpredictable. You could get a good result, or the patient could come back in 6 hours with an acute occlusion. So you wanted some, safety.
The present status of GP2B3 inhibitors like abciximab, etc.
Very rare if you have a no reflow and you want to do that. And I was a very good user of 2B3A because I felt it was a wonder drug and we produced less. But as I said, from the trials of intravascular ultrasound, most of those cases were under-expanded stents or not well-placed stents. And now with Brilinta, with Prasugrel, you have very potent antiplatelets. And as you said, now 1 month of dual, and you can then switch to just ticagrelor monotherapy, which is...
How long do you I mean, this for all of us, ticagrelor to continue.
See, India, ticagrelor and ecosprin combination is very cheap and generic. In the US, you will not be reimbursed beyond a year. So, you know, and that's costly for them. So from scientific point of view, a dual antiplatelet, like in diabetics or high risk, you found that clopidogrel added to ecosprin produced better long-term results. So it will prevent new atheroma formation, it will stabilize your plaque. It's not only for the stent, it's also for the new lesions which will come.
So at any point in time during the continuation of the DAPT, do you feel the need to step down ticagrelor or anything in terms of
Indian patients do very well.
Right.
At the most they have superficial bleeding, you know, some ecchymosis which you reduce or aspirin or whatever. But I haven't found major bleeding unless they are on triple. They're also on rivaroxaban or, you know, so for me, antiplatelet dual for life, especially in people who have left main, who have triple vessel, who have multiple stents, who tolerate for life. Because I'm not only addressing their stent, I'm addressing their you know, pan-carditis, you know, and they're going to form multiple areas. If you do an endoscopic examination, you'll find that MI is produced in the right coronary from one plaque, but that right is full of, you know, vulnerable plaques, which you have to whiten up. So you use high dose statin or, you know, dual antiplatelet as well.
Any preferences in the molecule?
No, I think earlier, for at least a year, giving prasugrel and ecosprin or Brilinta and ecosprin combination is shown to have mortality benefit, and I think then you can switch to clopidogrel. We had some you know, platelet activity machine with cartridges to tell, and we didn't find any platelet inhibition problem with prasugrel or Brilinta patients. Clopidogrel, you had at least 40% who were non-responders. So you don't know which patient of yours, you know, you're giving clopidogrel but he's not responding, unless you've done good platelet assays.
Right.
You know, so even in the initial Colombo trial, what he did was give ticlodipine was available then.
Yeah.
Ticlodipine and aspirin only for 5 days, or only aspirin. And these were patients, I was controlled, who did well even on one antiplatelet, and that is when humidin was to be given. So what the paper said is that antiplatelet, if you have a well expanded stent, even one antiplatelet is better than giving anticoagulation for your patient.
Thank you so much.
Sir, Dr. Bhandari, what a nice talk. I just want to inform you and the house that we belong to the same town, Bhiwani. 40-50 years back, Bhiwani used to produce doctors like you and me. Now it's more notorious for boxers and pehlwans and some other infamous things. Sir, my first question, although Dr. Tulsi didn't allow me to ask my 2.5 questions. Anyway, first up, in your slide you said early intervention is good. Like we have legacy effect in diabetes control. So is the same effect happening in the intervention also? If you do early, the overall effect and the quality of life will be better for future?
So there are some studies on doing, you know, vulnerable plaques which are just 40-50%, and using absorbable stents. So, you know, absorb studies are there from this gentleman who does the DCT, Greg Stone. So Greg Stone and Jagat Nagula are involved in that study, but that's to quieten down vulnerable plaque even if it is not occlusive. So it does work, but we need bigger trials to put it to general
But
use.
the restenosis, we know some of the factors like complexity and the location, the number, diabetes, so many things. Is genetic also any factor for restenosis?
Yeah, genetic is considered also one of the factors because some people hyperproliferate, they produce more new formation. So, but not well studied. There is, when you go through literature, there is a oblique remark to it, but it hasn't been aggressively studied. In fact, initially it was considered that restenosis is hyperresponder like a keloid. And what
Your chair is not stable.
Give me another one. Lay up.
I'm stable.
Government is stable.
I'm stable even if my chair is not.
Sir.
Okay. So, and in fact, initially I thought, we could do a study like, put a scar and see if he makes a keloid, he is going to have similar reaction in his coronaries. So, I don't know, we haven't studied it, but like some people after bypass develop big keloids, some don't. So some may be, producing more hyper sort of inflammation in the coronaries itself.
Sir, well taken, sir. Just for the sake of house and my own understanding, is there any upper limit of number of stents you can produce, you can put in a person, or the length of the stent? Beyond that, you won't go for a stent, you will go for CABG.
No, there's no limit, and in fact, in one of the studies, in one of the presentations in, I think it was in Bangkok, Dr. D.S. Kabir showed one of the LADs which he had stented from beginning to the end with a metal stent. And, Morris Bookbinder, who's a very elegant interventionalist from California, said, are you going to, do an angiogram on him every 15 days? So I wouldn't go there unless it's a, absorbable stent. So, but there's no limit theoretically if that stent works.
So my last question is about simplicity trial or whatever. Is it really simple or it is, I think, still complex? The denervation started with a bang, went with a bang, then came back. I don't know how much it will sustain. The denervation, it's a very complex subject actually. Because they at times claim that it will be with time improving beyond 100%. So it was a double question mark. Beyond 100% you will improve your hypertension. So when we think, we all say the diabetes and hypertension, they are all degenerative processes and they have to go with age. They will complex.
So there is a meta-analysis in JAC recently on whatever earlier trials are there, and what it showed is that very modest blood pressure decrease, just 6 millimeter or so. And the CSI National, I'm Vice President for National CSI, and they had on Hypertension Day, they had some sort of talk, and they asked me to review yoga and blood pressure. So yoga, especially the transcendental yoga, Maharishi yoga, help. So I was telling them that yoga, which is Indian thing, can produce better results than renal denervation. Why not do a large trial? But I think they're showing now some data of some trials showing 10 millimeter fall over a long period. So let it come back, we'll study it and see which is better.
Sir, I want to compliment you for a wonderful presentation.
Thank you.
And you took us to the journey of these stents, starting from bare metal stents to drug-eluting stents to absorb the bioabsorbable scaffolds, and now to the latest stents. Sir, you showed some slides about the absorb stents. Trying to convey a message with the mask.
Sir, what is the latest on the absorb stents?
So, absorb we know has been withdrawn, and largely it was withdrawn because of indiscriminate use and non-following of the protocols of using imaging more often or using high pressure dilatations. So, but some trials now which are follow up 2-3 years, where meticulous imaging has been done, where high pressure 1:1 inflation has been done, has shown very less late thrombosis. So even in what few patients I did, because we chose them properly, we post-dilated them, I did not find much problem. So it has happened in Europe, it has happened in India, where it mushroomed commercially, and everyone was doing without taking all the steps. So, but other magnesium stent also unfortunately has not come up to the expectation. There is an Indian stent which they show as good sort of long-term or short-term event-free rates, which is the my stent. But it's not come through large trials, and it's a very fascinating topic, and I don't think it's going to die. We are going to get a bioabsorbable good stent, and many companies are working on it.
Sir, I would like to ask on behalf of everyone who is there, when you use a very good stent, in the intervention, there are some considerations in your mind. The first consideration is, how long am I going to use a dual antiplatelet with this? Number one.
1 year.
Number two, what are the chances of bleed when I use a dual antiplatelet? I am asking this question to you, sir, because a lot of our patients we have been referring in the last about 7, 8 years, they have been put on ticagrelor. And Dr. Shubham Bats is an eminent gastroenterologist. I don't know whether he has seen an increased incidence of upper GI bleeding with, I will give you the mic. My impression has been that with the use of ticagrelor, a stronger antiplatelet along with aspirin, the chances of bleeding have increased. Not only minor, at times major, even intracranial bleed. So when you use good stents and you use a good antiplatelet, especially a dual antiplatelet, you mentioned prasugrel, even prasugrel is a stronger antiplatelet than clopidogrel. Clopidogrel, you said even there could be a non-responding rate of as high as 40%, but with prasugrel less and with ticagrelor even less. Sir, your experience over the last about 7-8 years, ever since ticagrelor has been launched into the field and has been used in a dual antiplatelet, what is your impression about the increased incidence of bleeding despite whatever Plato says?
So, I think Dr. Sen asked a similar question. I have seen intracranial bleed in people where you use a triple antiplatelet, which is rivaroxaban or any Novax, plus you have to continue dual antiplatelet because it's less than 1 month before you can stop it. And I've seen in one patient of that. Most patients with prasugrel, more so Brilinta, especially frail ladies, will report ecchymosis. And quite often, if I put my aspirin alternate day or even twice a week, rather than stop it altogether, even after 4 weeks, it usually abates. I haven't seen much bleeding unless he's on Novax. That's my impression. I may be wrong, because it depends on data, clinical studies, rather than your own impression.
Right, sir. Sir, from your talk, what I could understand and conclude was that the drug-eluting stents are still a very good bet.
Sure.
My message,
Perfect.
is that the message I am getting clear, sir?
Yeah.
Right, sir. If drug-eluting stents are good enough, and they are the best deal that we have right now, does it decrease the need for dual antiplatelet from 6 months to 3 months?
So, I think even at 4 weeks, the Onyx OCT data, the Giants OCT data is there, and they get about 94% endothelized. And that's why many companies were not making a 2 millimeter stent. It came, I think Onyx made the first 2 millimeter, except for, the German stents, but none of the US, but now you have 2 millimeter, 28 millimeter length, even with the new, Zionscom family. And people are, when 2.25 came in Cypher, even 2.25, 33 was there. That shows the company's confidence in their animal data, in their clinical data, that they are willing to produce, especially in the US, you have one problem, you can be litigated and become bankrupt. So that shows the confidence of the clinical data, of the experiment data of the companies which are bringing out thinner stents and longer stents. So,
what is the minimum period of DAPT that you recommend if somebody who has gone through what study does?
no, so as I said, if a person is on dual antiplatelet and bleeds, you can continue one, which is, say,
He goes out of your guideline. You put in 2 Xan stents, for example, and then what is the recommendation that you give? 6 months, 3 months?
DAPT 3 months, 6 months, 9 months, 1 year.
if it's not a high-risk bleeder, it's not a CKD patient, very elderly, frail or something, I would continue for long term. Which is, as I said, if they tolerate it for as long as they can. Because for me, cost is not a price, reimbursement is not a price. I am gaining for myself confidence that, as I said, in the diabetics or high-risk group, adding clopidogrel to aspirin in the, I forget the trial name, I think it's the Capri trial or some trial, which showed definite evidence of benefit of a dual antiplatelet in high-risk CAD subgroup.
Because why I am asking, and sir is also asking, sir, because in between there was a feeling that one can safely stop after the year.
Yeah, you can stop, but some of these trials where it has been stopped, bleeding has reduced, but their events have increased.
It will all depend on the ischemic risk plus the
No,
bleeding
but
risk.
when you are asking somebody to stop after a year, how long can you monitor it? The patient in India is not going to come back.
It should be individualized. It should not be a blanket one. It
Sir,
should be individualized.
sir, what I want to tell you is, and my respected fellow members is, that ticagrelor is a very good antiplatelet. But please understand that ticagrelor comes with a price. There are absolutely reasonable chances that your patient will get either a minor or a major bleed. So be careful about that. And as you mentioned, sir, the case that you said, if there are any evidence of ecchymotic patches, be prepared for a major upper GI bleed, and keep that in mind. Right, sir. I'll stop my DAPT questions on that. Sir, you mentioned about TAVR, and I understand you are doing it, sir.
Yeah.
So, with the Indian valve, if I send you a case of aortic stenosis, sir, what is the overall package of TAVR if the patient stays, let's say, for about 3-4 days in your center? What is the minimum package of TAVR with an Indian wall?
So it's
Sir, please take the mic, sir.
it's about 15 to 17.5.
It is with the my valve that you
So
showed.
the MyWell.
Okay.
So the MyWell they sell for 12.5, and there's a hospital for charges about 3.5 lakhs extra. But if it's in a single room, then it gets more.
What do you use, DAPT or anticoagulants after you put the wall?
DAPT.
No use for an anticoagulant?
No.
Great.
No. It's just 4 weeks of dual antiplatelet and then one antiplatelet.
Only one antiplatelet. Probably aspirin if I understand correct.
Aspirin or clopidogrel, more often clopidogrel.
Right. Dr. Shubham has some questions. Our DM gastro friend.
Very good evening. So I'm practicing gastroenterology for the squats in Faridabad. So the only thing I want to ask you is, so you stent the patient and on day 2 he bleeds. So I do an upper GI. I see a malarious or a gastric ulcer or a duodenal ulcer. Fine. I clip the malarious or I do a sclerotherapy, bleeding stops. The only thing is that now I cannot give the patient, as a gastroenterologist, I cannot give the patient an anticoagulant or an antiplatelet. But my cardiologist friend is calling me again and again, "Kya मेरे को शुरू करना है, तू बता." So there are no guidelines in gastroenterology which tell me that when I can start it, because it's a antiplatelet induced bleed. So that's what I was telling sir. That's what I was about to ask. So my only question is that there's a 50-year-old man who's a non-smoker, had a double vessel, triple vessel disease, you stented him, he's stable. But on day 2 at 3 a.m. in the morning, I get a call that he's bleeding. I go in with the scope, I find whatever. I put a hemoclip, bleeding stops, patient. The next morning, all antiplatelets have been stopped. Next morning, patient is hemodynamically stable. But the cardiologist friend is behind my back. I want to start, I want to start, I want to start. So where's the safe zone where I can start? So this is one. Second is, if this was chronic, suppose it was 6 months, you are continuing, as you said, it's case-based, and this happens, what you will do in that case? That's all right. Thank you.
So we have this problem quite often. See, the cardiologist is worried about some acute closure, and when we started angioplasty, I think he remembers we had big hematomas because we didn't worry about Coumadine, we didn't worry about IMARs, we only worried about the heart, because if he has a heart attack or something. So I would give, because clopidogrel and ecosprin are going to be effective for a week, I would give him 2-3 days and watch, whether Trombryl's tube is actively bleeding, give him top of the line PPIs, and watch his, hemoglobin. So I would go on the side of restarting. I don't know, some studies have shown clopidogrel to be a worse offender for GI bleed than aspirin even. So I would start with something, and for me, what has worked is starting silestazole. Silestazole is a weak antiplatelet, and we used to use it with ecosprin, clopidogrel, and silestazole. Came from South Korea.
It's an old phosphodiesterase.
Yeah, I used it again. I'll tell you this patient, and this helps, at that period because it's a weak antiplatelet, but probably doesn't cause GI bleeding. So that is one thing. I would go with that and then gradually build it up. And now you have, if your patient is having problem, you have fast-acting cangrelor is available. So you can do many things. So I'm just talking about a patient who has been my follow-up. I did angioplasty way back in LAD, and then I moved places, and he didn't go to Escorts. He found I wasn't there, moved to Metro, got multiple stents in right and served, and now came to me after I moved back saying that he keeps having melena off and on. So his endoscope is okay, his colonoscope is okay, 6 months is okay, then his study bleeds. And then he, does that for 2-3 days and is stable. Now he came this time with melena, hemoglobin of about 4.5. So we transfused him and he started having chest pain with ECG changes which were like a left main. 5 millimeter ST depression all around and some AVR elevation. So we needed to do an angiogram and know how many stents have been put, is it a left main or whatever. And so he, luckily his hemoglobin built up, his hemoglobin came to around 8 with 5-6 transfusions and his melena stopped and he didn't have a stool for 2-3 days. That means he's not having melena, otherwise it will open up. So we angiogrammed him and it was a large circumflex, 1 stent. And LAD has a big stent all throughout, many stents here and there. So he has to be on some antiplatelet. So we stented him for the circ and he went home. 2 days back he's again with a melena. So what do? So I've stopped his EcoSprint, put him on plateaus and made his clopidogrel. We give it twice a day. We made it once a day and said if he rebleeds I'll stop his clopidogrel and be on plateaus. But it's an art. There's no science in it. There are no guidelines. You have to use your judgment and that's where the real physician comes in. I think so.
Antiplatelet. So you're like my cardiologist friend who says, why antiplatelet show kara?
He's worried.
I take this opportunity since sir mentioned Jagat Narula, my very small current and my district cardiology. I quit a DM cardio after my MD because of family circumstances. But my professor, the Dr. San was Jagat Narula and I had the privilege of assisting him and Dr. Shani Sharma in the Jaipur cath. So I would always remember that. I think Dr. Sharma.
Sir, Dr. Sure.
I'm sorry.
Go on, Naresh.
Sir, I have a very simple question. हम मार्केट में जाते हैं, कार खरीदते हैं सर, 2 साल की वारंटी, 10,000 रुपये दे दो, 4 साल की वारंटी। मेरा क्वेश्चन ये है कि अगर कोई एओर्टिक वाल्व रिप्लेसमेंट की बात आती है, 17 लाख, 16 लाख, 15 लाख खर्च करता है, तो उसकी वारंटी क्या है सर? क्वेश्चन है नंबर 1। नंबर 2, स्लिप कर गया, ब्लीड कर गया, उसकी किसकी जिम्मेदारी है? दैट माय क्वेश्चन।
सर कोई वारंटी है ट्रैवल की बात?
एक्चुअली पेसमेकर की तो होती है, once you put a pacemaker which is now dying down, that it was considered a very poor country 30 years ago, so the battery was given free, So initially, that's what I told some of the stent companies, that the restenosis is 15% or 20%. Figure that out in your first, financials. So if the stent is 20,000 or 50,000, 20% restenosis, make it 75,000 and make it for life. But very few companies do it. It's for corporates or for people who manufacture, they have a different brain than a physician brain.
Sir, this is the professional guarantee, not the instrument guarantee.
No, you can't have any guarantees. मैंने मारुति खरीदी थी पहले 800, बाहर निकालते ही वो बंद हो गई थी. I had to take it back.
आपने वो extended warranty नहीं ली होगी सर?
I think friends, we are approaching 11 o'clock and we have a duty to wind it down. I think it was a wonderful presentation by Dr. Suman Bhandari. Some excellent questioning as always by Dr. Tulsi sir, and some half questions by Dr. M. Kalra sir, and I pitched in with some of my own stupid questions. I think it's time now to ask Dr. SenGupta sir to summarize this for us. Few carry home messages.
Thank you, Dr. Sean. I mean, it's been a wonderful evening, and Dr. Suman Bhandari sir has very successfully gone through the entire journey of development of interventional cardiology very beautifully, and all the questions asked have aptly, kind of cemented whatever was there to ask, and I don't have actually anything to add. And thank you so much, Dr. Bhandari, sir, for being there and delivering this marvelous.